Hi, everyone. I'm Jen Farmer from the Friedreich Ataxia Research Alliance, and really excited to welcome you to the webinar that we're hosting today with Solid Biosciences. This is an opportunity for you to learn from the Solid team about a gene therapy program that they've been developing for Friedreich's ataxia. And just a quick housekeeping item or two before we get started. We welcome questions from the FA community during the discussion today. To submit a question, there is a Q&A box at the bottom of the Zoom screen, and so you can just open that box and type in a question. Some folks submitted questions in advance. Thank you for doing that. Some of those questions we'll be able to address actually during the webinar and the information that's being presented, and some Helen Madden, FARA's patient engagement manager, will be bringing forward during the Q&A. So we've got some questions all ready to go for the second part of the presentation today, but please don't be shy with your questions. So this is what will be the first in a series of a few webinars that FARA will host with Solid so that you can learn about this program. The goal of this first webinar is to give you background about Solid Biosciences and their gene therapy program. And then later in the year, we'll do another webinar where we'll be able to provide more information about upcoming clinical trials. So this is really, again, to give a first introduction to the Solid team and their program. So with that, I'm going to introduce you to the Solid team joining us today. We have Matt Harmlink, who is the therapeutic head of neuromuscular at Solid, and Annie Gano, who is the co-founder and senior vice president of patient advocacy. And Annie, I'm going to turn things over to you now.
Awesome, Jen. Thank you so much. While Matt kindly brings up our slides, I just want to thank you, of course, and the entire FARA team for hosting us today. And of course, thank you for all the incredible work you do to support the Friedreich's ataxia community. We're honored to be here and really grateful for the opportunity to introduce ourselves. We can go to the next slide, Matt. Thank you. So that's me on the left. I'm Amit Ganot. As Jen kindly said, I'm one of the co-founders of Solid, and I lead patient advocacy. And I'm joined by my colleague, Matt Harmelink, who is the head of our neuromuscular team. Next slide, please. Okay, so before we dive in, we're a publicly traded company. I would like to draw your attention to this forward-looking statement slide, which reminds us that some of what we'll discuss today involves future expectations that may differ from actual outcomes. Next slide, thank you. So as Jen kindly already shared in terms of our agenda, we're going to provide an introduction to Solid Biosciences. We're going to dive a little bit deeper into gene therapy and specifically, our approach with our investigational candidate, SGT-212 or 212. And a lot of the unique properties around this candidate, specifically to address both the cardiac and central nervous system challenges of FA. Next slide, please. Okay, so before we dive in, I just want to provide everybody a little bit of background about Solid. We were founded in 2013 following my son's diagnosis of Duchenne muscular dystrophy. Like so many of you, my family was confronted with the urgent realities of a progressive, rare disease with little to no treatment options. That experience led us to create Solid, a company built with and for patients, with a mission to develop meaningful treatments for patients living with Duchenne. Now, over the last couple of years, Solid acquired Avanti Bio, and we've expanded that mission to include Friedreich's ataxia and additional rare cardiac indications. Of course, we recognize in FA there is a clear need for innovation, an incredibly engaged and resilient network of families and advocates, strong patient advocacy, and an opportunity to advance a therapy that could potentially provide meaningful benefits to patients. And a little bit more about Solid. We are based in Charlestown, Massachusetts, which is an area of Boston. We are a clinical stage company. Right now we are in the clinic with a gene therapy program for Duchenne. But if we go to the next slide, we can show a little bit more of our pipeline and to get a better snapshot of where we are. So I mentioned that is our 003 program for Duchenne muscular dystrophy. We are treating patients in a gene therapy program. I should also mention that this is a next generation program for Duchenne. We were in the clinic with a previous program, but we were able to make refinements to our capsid, our manufacturing process. So this isn't our first rodeo in gene therapy, and there is so much that we have learned, and we have partnered with the Duchenne community and our brave patients and families, and really taking all of that expertise and applying it to FA. In addition, we have a cardiac pipeline. So we are marching towards the clinic for a rare cardiac indication called CPVT, which is an inherited cardiac arrhythmia, and a few additional programs that you can see on the pipeline that are in sort of preclinical and discovery stage at this moment. So that's a snapshot of Solid. And as Jen kindly mentioned, this is really the beginning of a series of webinars to really make sure that we are providing transparency, updated information, having the opportunity to address the questions of the community and make sure that we are on this journey together. We want to make sure that we do everything we can to provide information that makes sense, that supports families, and really truly incorporates the patient's concerns, feedback, and thoughts as we move forward in this process. So thank you so much for having us. We can move to the next slide, Matt. Brilliant, and I will pass it to Matt. Thank you so much.
Thank you. Very excited to be able to talk today. And so we're going to start off, as I sort of was already mentioned, a little bit with the idea of what is gene therapy and walk us through. I'll apologize to those of you who've been engaged with gene therapy before, but we did want to start at the beginning, which is where we should begin, and then sort of walk through the pathway, eventually getting to some of our preclinical data. So we're going to start at the very beginning. What are genes? Because I think this is so important to understand as we look at gene therapy and the program that we have at Solid. So if we think about all of our cells, in each cell there is a nucleus, or most cells. There's a few exceptions. I'm a neurologist, so there's always an exception to every rule in neurology. But in most of our cells, we have a nucleus, and inside we have our chromosomes and our DNA. And on each of those chromosomes is hundreds of thousands of genes. Each gene is made up part of this DNA, or deoxyribonucleic acid. That DNA is coding for the different proteins that make the infrastructure of our body. Now, every nucleus and has all these chromosomes, and every gene in our bodies and every nucleus, but only certain are expressed in different cells, and I'll talk about that a little bit later. But the idea behind is that those genes that are expressed in a certain cell get translated into RNA, which then gets made into protein, and that protein becomes a building block of who we are. That's really important as we talk about gene therapy, because how we affect a disease and how we treat a disease will depend on what part of the pathway we are engaging with, and where we're actually using medications. So specifically with Friedreich's ataxia, we know that Friedreich's ataxia is caused by a mutation, or some people also call it a variant, in the FXN gene. That gene encodes for the frataxin protein. Normally, frataxin DNA has a certain length. And when we think about a gene, one other thing to know is that a gene is not just a continuous gene. There's actually parts that are kept in the cell become proteins. There are parts that are not needed. They're called introns and exons. Exons exit, introns stay in the nucleus. The important part is that in Friedreich's ataxia, the frataxin DNA can become too long at a part of an intron. That means that it leads to a lower amount of frataxin protein later. So normally in this one area, we have this repeat of letters, GAA, 7 to 12 times. So it's GAA, GAA, I won't say it over and over again. But that repeat length is okay. We don't have disease. If that length gets longer and longer, it eventually can cause a problem where the frataxin protein isn't able to be expressed. As a result, cell toxic byproducts start to accumulate, and they can cause cell dysfunction and death. And so that's where people who've had genetic testing before will hear back they have a certain repeat length. Now we obviously have 2 copies of these genes, so we would have 2 different copy lengths that would be reported out on participant or patient going forward. This is important though, because we now by doing that, we can focus on this FXN gene as the gene that's causing the disease in Friedreich's ataxia. The other piece to know, and this is sort of alluded to here, is that in Friedreich's ataxia, it's a loss of function disease. And I'll mention that a little bit later when we talk about gene therapy. That's different than some diseases, which are gain of function, where you have too much of something. And that's important because replacing a gene or treating a disease or adding more into a gain of function disease probably is not going to help as much if it's the thing that's too much. Whereas in a loss of function disease like Friedreich's ataxia, we could replace that protein and actually gain functionality. So what is gene therapy? And I think, again, very important as we think about our DNA, what's going on in Friedreich's ataxia, to differentiate between two major discussion points that sometimes get confused. In gene therapy, there is gene replacement therapy. This is where a company wants to introduce a healthy version of a gene into your body. The purpose of that drug or that genetic change is not to make changes to someone's DNA. If you'd look at their DNA, they would still have the change that would cause the disease in addition to this healthy gene or part of a gene, depending upon the disease that you're looking at. That's different than gene editing, where the purpose there is to actually go in and change someone's DNA such that it is now back into a normal frame or a frame that wouldn't cause disease. For SALAD, we're focused on the gene replacement therapies in Friedreich's ataxia, not necessarily looking at it as a gene editing modality. So if we look at gene replacement therapy, then we can break it down into three major areas. What do we need to actually come at this disease? Well, one is a question of how do we get this gene, or what we'll call transgene, into the cell? How do we make sure it's expressed? And then what are we putting in? So there are lots of different ways that people have talked about delivery vehicles. Viral capsids or virus capsids are probably the most common right now, and it's something that SALAD is using as well. We know that viruses like to infect cells, like influenza, a bunch of other viruses, and they oftentimes will have certain tissues that they like to infect. Certain viruses make us vomit because they go to the stomach, others go to the lungs and cause respiratory issues. So you can select a virus for the tissues you want to have it go to. Inside then, before every gene, there is a little bit of a promoter, I mentioned this before, that actually helps express the gene. As I mentioned, in our cells, we have all of our chromosomes in every gene in every cell, but we don't want the wrong protein in the wrong cell. I don't want a cardiac-specific protein being expressed in my brain, and that's where there's a promoter before the gene that can be turned on by other features in that cell to say, make this DNA into a protein. And then in our gene replacement therapy, there's also the idea of a transgene. What do we actually want to deliver going forward? So if we start off with the idea of the viral vector, what do we need? So AAV, which is the class of viral vectors that we're talking about for this case, stands for adeno-associated virus. In gene therapy, we also call this a viral vector. This is different than adenovirus, which you may have heard about causing infections, different type of viruses. Still both viruses, but different. The adeno-associated viruses also allow us to introduce a modified gene into cells, many cells at once. Now, this is not something that's new. It's been around for a while. The first AAV gene therapy trial was actually done back in 1995 in cystic fibrosis. And currently there are 7 AAV gene therapies that have been approved, 5 of which are by the FDA. So it is something that has gone through trials in other diseases. Now, it may not be this, actually it is not this viral capsid. For our study, we're looking at AAV HU68, and I'll discuss a little bit later, but the actual subtype of AAV does matter quite a bit. And there are many different types of AAVs. So as we start to look at the target tissue we want to actually get the transgene into, someone can subselect their serotype. So for example, in our program, we're looking at a subtype of the AAV9. AAV9 is a viral vector, likes to get into tissues like liver, heart, brain, skeletal muscle, lungs, pancreas, kidney, which would make sense with Friedreich's ataxia, knowing that there is involvement of many of these organs. Now, the AAV HU68 is in an optimized version of that AAV9 so that we can select certain structural pieces of it that we like better as we go forward. However, you may hear about other programs that are out there or other approved drugs that use different viral vectors because, for example, if you're using an AAV4, you're really just selecting for central nervous system and retina. And so each of these can be bases, and then you may hear people start talking about modifications to those further, like we've done at SALAD, to try to be more specific. So how does the virus actually get there, right? So the idea is that's great. We talk about this viral capsid, and once you get the capsid into the body, it will have to engage with the cell you're looking for. Now, typically there are proteins on that viral capsid that can help select the tissue you're looking at. And if you look at this diagram here, you'll see there's the membrane of a cell as this light blue line. The cytoplasm, if we think of a cell being sort of a round structure, is where all this other stuff that happens in it. And the nucleus, where I mentioned the DNA, is on the inside. Now, this nucleus is bigger for dramatic purposes. Typically, it's quite a bit smaller relative to the size. But that virus will then engage with the cell. It gets encapsulated into the cytoplasm. It will then actually be moved into the nucleus, where the vector, when it's inside the nucleus, will actually release its DNA construct. Now, again, this is a gene replacement therapy, not a DNA editing therapy. And the DNA construct forms an episome, sort of a little circular ring, still double helix because it is DNA. Does not incorporate into someone's DNA is not the goal. And then from there, that DNA template can start producing the new protein. In the case of our program, we want to produce frataxin protein inside the cells. That protein goes outside the nucleus and then can start functioning as a protein should. So that's the viral capsid. Now, if we start moving along then to the promoter, the idea is, what does a promoter do? Now, in our program, we're using a CB7 promoter and enhancer elements, not something someone will need to memorize necessarily remember, but what is important to know is that the promoter helps determine what tissue is in expressing. So what is a promoter? A promoter is a part of the DNA that controls where the gene can be turned into a protein. This allows us to control in which cells a gene can be expressed. So for this experiment or this discussion, this is not necessarily referring back to our product, but if you have a viral capsid, let's say, that goes and can actually get your DNA into both a brain cell and a kidney cell, and then there's a promoter that can say, well, only in the brain cells is it turned on. We know that gene will then be expressed as a protein in the brain cells, but it would not be turned on in the kidney cell because the promoter is only for brain cells. This allows some subselection. Now, it is a bit more complex where promoters can actually be variable and they can have variable expression in different tissues as well. So as you think about promoters in general in DNA and things like that, it is something that it can change based off the tissue type you're looking at. It's also important to note that all of our genes have promoters as well. This is not something specific to just gene replacement therapy. And each gene can have multiple promoters. In some genes, not necessarily as much in frataxin, you can have different size proteins from that gene based off where the promoters are and what tissue. So it can become a much more complex controlling mechanism that way. So then we come to the idea of the transgene, right? This is the product that we actually want to get. So in Solid's case, we're looking at a frataxin gene, the frataxin protein. It is a little optimized and changed in terms of the exon intron pieces from what you'd find in a human normally, and that's just based off packaging and how it's promoted. But really, the goal is to make that protein of pure frataxin. I'm jumping into risks after this because I think it's really important that we talk about not just the potential and the mechanism, but also what are the risks of viral vector gene therapy. Now, when I mention potential risks, at this point, we have not treated patients with our product for Friedreich's ataxia. So I'm looking at the class of drugs, the theory of what could happen, as well as animal models, both for our studies and not. This is a very broad discussion, not specifically just about our potential therapy. But when we look at potential risks, there's things like oncogenicity. We mentioned that DNA is inside the nucleus, and if there's an engagement with your DNA, could it cause risk of cancers or things like that? We know liver injury can happen. A lot of, as you may have caught from the previous slide of all the different viral vectors, these viral vectors like to engage with the liver a little bit. And like any virus, if you get exposed to it, your immune system should and will react to this. You can have an immune system reaction to this. One of the areas that people worry about is heart inflammation because of that immune reaction. So those are all some potential risks of being exposed. Now, there's also the risk, because this is a type of virus, is if you have it or if you've been exposed previously, you can already have antibodies to that capsid, to that viral vector. That's important because as we look then at the idea of what would happen if we gave someone who already has antibodies to a virus, it would be very similar in that they'd probably not get as much efficacy of it, benefit from it, and they might have a worse reaction to it. So those are one of the risks that have to be looked at. Now, there's ways we can mitigate this, and this is done across the field with gene therapies. One, we can use immunosuppression, helping with the risk of heart inflammation, immune system reactions, and that's a pretty standard thing across many of the different gene therapy programs. It's also in a trial, we would do frequent physical exams, lab testing, really to make sure that anybody who gets this gene therapy, which is a one-time dose at this point, just to be clear, and gene therapies are thought to be just currently able to be given once right now in our current scientific settings. But the idea is that we watch patients very closely, especially in the first couple of months. But this is something else that we do want to have a long study duration. These are not research studies that are weeks or months. These are the idea of years. And long-term follow-ups are really important so we can follow for some of these risks. Some we know are more just around the time of dosing to a few weeks or months after, but things like oncogenicity or long-term effects, we do also want to follow. And then we also have to be very careful in evaluating prior to dosing, making sure someone isn't sick, they don't have other risk factors, things like that, that could increase their risk. I say all this not to say it doesn't have significant potential. The field certainly does, as well as I believe our product, but it's something that we want to be aware and very transparent about, that this is something that is a complex topic and requires a lot of discussion with your physician and you about whether you'd want to engage in a study like this. As I mentioned before, we can reduce these risks. We can do things like finding the right dose, and I'll mention a little bit of that as we look at the preclinical data going forward. We have to make sure we select patients appropriately for a study. Now, this is not that we only want to be picking patients that are, we don't want to pick patients, I should say, then have the right results, but we want to make sure it's safe for patients to be engaged. The right time, the right patient is really important. And then again, that idea of using immunosuppression and other medications to help reduce those risk factors as able. But why is FA, here it says challenging, but also very an exciting disease to talk about treating? One, it affects a lot of different systems. It's a multi-system disorder. So not only do we have one organ in one system, but we sometimes have multiple systems in the same organ system. As a neurologist, I think of the brain and the spinal cord, and the sensory nerves are all affected in FA. The brain can be difficult to reach with therapeutics. That's actually one of the difficulties. We have this beautiful thing called the blood-brain barrier that keeps out sort of a protection between the rest of our body and our brain and spinal cord. It's wonderful because it means every time you get a runny nose and a cold, you don't get meningitis. However, it also limits things like drugs and how they cross over. And so we have to be thoughtful of how we approach the brain that way. In Friedreich's ataxia, patients have all different symptoms, different progression of symptoms, and at different times. And so how we treat one patient will be a little different in terms of what we expect from someone else. And the last thing is from the animal studies, is we know that sometimes frataxin can be harmful if you make too much. So it's not so much as we want to just go and dose as much as we can. We want to dose the right level to the right organ. I'm going to take a breath there, and I apologize, I do speak very fast, but we're going to move then into some of the preclinical data and sort of the pre-human trial discussion as we move forward. But let's first talk about drug development. And I think it's really important not only to talk about drug development, but where this drug came from is really exciting. So this actually started with FA212. This is a company founded by two fathers with children with FA. They worked with the University of Pennsylvania and did some of the early non-animal testing and then went into animal testing as well. They continued that work. And as they got to the animal testing, it became discussions of, is the drug safe? What's the optimal dose? Are they seeing a potential benefit going into humans? Then those groups reach out and work in collaboration with Salad to create a clinical protocol. And we received FDA clearance to proceed to the human trial as from our company. Again, with the questions of, as we move forward, how do we make sure this is safe? What's our optimal dose? And what type of effects could we potentially see? Now, one thing to note about our trial, I know the next discussion, next talk that we give, we'll be talking a lot more about details about the trial, but I think we want to have some very high level pieces. And one of those is that we are actually doing a dual route dosing. So this means that we're actually going to be giving the drug in two different ways at or near the same time in a participant. One is that we're going to be doing what we call direct dentate nuclein fusions. So as I mentioned before, there's this blood-brain barrier and we have this difficulty of crossing it. Our approach to doing this dosing is actually to directly administer to the brain structure that we want to treat, the dentate nuclei. And this can be done through a neurosurgical approach where they can actually infuse the drug via stereotactic neurosurgery. It sounds very fancy, but under imaging guidance, they can actually show where the needle is and infuse the drug just into that tissue they're wanting. So it's a very focused, very precise way of delivery into the brain and to specific targets in the brain. In addition, we also want to be able to focus on treating the largest cause of mortality in Friedreich's ataxia, the cardiomyopathy, and potentially other symptoms. And with that, it'll be using intravenous route, so through an IV, so you get more systemic dosing. So we'll be both dosing in the blood-brain barrier as well as without. And as I talk about the preclinical studies, that's important because you'll hear a little bit about the procedure and things like that too. But first, why the dentate nuclei? So if we think about our brain, we have our couple parts. We have the cerebrum, which is where we typically think of our thinking to be from, right? That's as you look over on the right side, that's the pink structure up top. The cerebellum, which is Latin for little brain, is that sort of yellow piece down below. The cerebellum plays an important role in coordinating motor movements, balance, posture. The dentate nuclei are inside the cerebellum. It's a small piece, sort of more in the centerpiece of the cerebellum. You can see a little bit where the red arrow where it is. And this is one of the main checkpoints for nerve signals leaving the cerebellum. This is especially vulnerable to loss of the frataxin protein. So if we think from a neuroanatomy perspective of how we want to have a movement, the front part of our brain, which tends to be the frontal lobe, people have heard of that, that's where we think about, hey, I want to move. So if I want to move my finger, front of my brain thinks that. That sends a signal back to our motor cortex, which is right on the side here, that will say, move that muscle. As that signal then goes down through some deep tissues called the basal ganglia, that's sort of the center. It says, can you move it? Yes, let me. And then the cerebellum tells you if you're moving too much one way or another. So if you overshoot or undershoot, which is why if we don't have good cerebellar control, we get ataxia because it's not able to control that over and undershooting as we reach and start moving for things. Now, if we move into the animal studies, there are going to be three types of animal studies we're talking about. One, there's going to be the mutant mice or variant mice that have a cardiac phenotype, the heart phenotype. There's that type of mouse that has the neurologic phenotype, and then there's what we call the non-human primates or types of monkeys and other primates there that are healthy. In the cardiac phenotype mice, so that's a mouse that is changed to have a phenotype for FA. They were tested for safety, survival, changes in frataxin levels, effect on cellular function, heart function, and also looking at different doses. The neurologic phenotype mice as well were tested for safety, survival, change in frataxin levels, effect on motor function and that function on the nervous system, and some dose-dependent effects. And then in healthy non-human primates, they were tested for things like safety, changes in frataxin level, dose dependency, but also the feasibility of the surgical approach. Now, the surgical approach of stereotactic neurosurgery has been done for other indications, has been used in gene therapy trials as well as other surgical treatments. So that is not the new approach. We're really looking at the idea of how can we do drug delivery to this target tissue in a non-human primate. And so if we start off with the cardiac phenotype mouse, in these mice, there are a couple of things that we could look at. As you'll see through the next couple slides, the black diamonds are the healthy control mouse. Next to, so that light blue, that's the mouse that had the frataxin knockout. And you can see in where it says cardiac expression, that's looking at the positive cardiomyocytes for the frataxin gene that we're wanting to express from the gene therapy. There's a couple different doses tested, and you can see as you move through the doses, you're seeing an increase in positive cardiomyocytes. So showing a dose response that there is expression in the cardiac tissue. In the middle table and graph, you'll see that this is looking at left ventricular mass index. So at day 30, so the mice are dosed, and we know that this LVMI is correlated to increased risk of all-cause mortality. And so what we see is, again, we're starting off with the healthy controls. As you move up to the mice that are affected but not treated, you see an increasing index, and that starts to come down closer towards the normal mouse as we're going forward. And then finally, we can look at mitochondrial function. SDH is an enzyme inside the cells. We also can use it as an indicator of how well the mitochondria is functioning. The higher the value, the lower the activity, sort of a flip of what we saw in the others. So what we would like to see is being closer to this normal mouse. As we see, there's the mouse with the knockout is here, and as you have a dosing, it starts to come back closer towards normal. If we move into the neurologic mouse, we have two different types of assessments we can talk about today. One is the neuro score. So the neuro score is, there's different categories of neurologic function in these mice that are assessed and scored. The range goes from 0 to 17. Higher scores are worse functioning. So sort of similar to the mFARS, the higher, the more disability the mouse might have. Again, you can see that the mouse who is unaffected is down by 0. As you have the knockout mouse, you have an increase, and with dosing, we start to see that at day 56, neuro score coming back down, showing that there is an effect on the neurologic function. If we move to the rotor rod, which is where they have a test where the mouse has to balance on a rotating beam, the longer the beam, the better. So here we want a higher number for it to be more close to that normal unaffected mouse. And again, we can see the unaffected mouse, the affected mouse, and then the change as we look at treatment up to day 60 of the 3 different doses going forward, as well as demonstrating that there is effect from the drug on these mice. Now, I'm shifting over a little bit to the non-human primates, and these are our healthy non-human primates. This is a diagram actually of a non-human primate brain. It will look different than the diagram before based off structure, because we're looking at the other brain was a human brain picture. But this actually also shows this dentate nuclei right down here. It is smaller, but it's very, very important in neurologic functioning. And this diagram actually shows this human frataxin RNA and looking at where is it localized in the dentate nucleus. In this case, it would be red. And what we're looking at here is the idea of the red, and the red exposure is throughout the dentate nucleus of all 4 of these non-human primates that were tested and then evaluated afterwards, showing that it is a wide distribution from the infusion, not only in certain areas necessarily. As we start to move beyond just the preclinical data, Annie alluded to before also the idea that there was work actually at Salad and Avanti Bio before they merged in Friedreich's ataxia as well. So Salad has a robust understanding expertise of FA through a lot of preclinical work. Overall, in combination of all these studies, over 9 non-human primate studies were conducted across 4 different development candidates. So not only this SGT-212 with over 120 non-human primates tested. There were different dose levels tested across different routes of administration. So it was an approach of where IV was tested. IT is intrathecal, so that's actually like a lumbar puncture or a spinal tap, infusing there alone. Evaluation of IV with the IT, so through the vein as well as through the spinal tap at the same time, and then IV and IDN, which is what we're moving forward with in our program currently. We decided on was the best route, which is what I mentioned, which is through the IV as well as the surgical approach. Follow-up times were long, with some of these animals as long as 360 days post-dosing, including with SGT-212. Now, it's also important as you look at the non-human primates, we talk about toxicology. And so there was dose-dependent and long-term biodistribution in non-human primate tissues associated with corresponding expression of this transgene in both the heart, the dentate nucleus, and the dorsal ganglia. The precision of MRI-guided IDN procedures was safe and well tolerated by these NPHs. And the proposed clinical ID and IV dose levels didn't have any treatment-related findings in both the CNS and non-CNS tissues. So that's what led to this proposed clinical ID and IV dosing, because it also listed what we thought was therapeutically relevant levels of frataxin expression. So what's next and where do we go from here? We have received permission from the FDA to conduct a phase 1b trial in the US. The trial is aimed at evaluating the safety of this gene therapy as a gene replacement therapy, with the goal of hoping to start dosing by the end of this year, 2025. As mentioned before, more details on the study design are going to be presented in the second webinar. We wanted to sort of start with the introduction of gene therapy and some of our preclinical data today. And with that, I know we have some extra time, but I wanted to make sure we had the ability to answer questions as we go forward. So thank you.
Matt, thank you very much. You covered a lot of ground, and you are correct. You talk super fast. You slowed it down for us a few times. I appreciate that.
That was slower for him, Jen. Like
I know you were totally into it. I could tell, and really appreciate that. Kellen, we've got a lot of questions. This is terrific. So maybe I'll turn it over to you to ask the Solid team the first question.
Sure. Yeah, I've attempted to try to put them in categories, so we'll see how that goes. I think maybe we should start with some of the questions that are more just about gene therapy in general, and this could apply to any type of gene therapy. So I think one question that people always have about gene therapy is the question about getting gene therapy multiple times. Could you talk a little bit more about why that isn't currently possible?
Yeah. So when you get a gene therapy, especially viral vector mediated gene therapy, your body is going to see that virus as a foreign piece. And just like any virus, it develops an antibody to it, right? It's the smart thing to do. Our body should be doing that. The unfortunate thing is, and afterwards, you have that antibody and that memory of that immune reaction in your body. And so if you try to dose someone again, and this is with our current understanding, there's a lot of work across the industry, across diseases on how do we approach this. So I want people to take that away. But with our current understanding, then, if you give someone who has that antibody, the viral vector, their body would fight it off. And it either could be not efficacious, it won't actually bind to the cell and get inside, or you could have a worse and unsafe immune response. So those are the pieces that make it sort of a one-time dose. It again, I will leave it with maybe a positive note of there's a lot of interest in how we address this across the field right now.
Right, and part of the design of SGT-212 is that it's targeting multiple organs at once as well. So that is one way to address multiple dosing, is trying to reach multiple organs at once.
Yes, and that would exactly, because if we can only do it one time systemically, and there's some caveats on the blood-brain barrier and crossing, and that could be a whole fun rant that I could give, and I will not. I apologize. I promise, or I promise, I should say. But I think the idea is if we only get one good shot right now with our current knowledge, we want to address as much as we can and target the disease as a whole, or as much as we can as a whole, with multi-organ targeting rather than just with one approach on one organ.
And can you talk a little bit about, and I think you shared a little already about this, but based on what we know about gene therapy in other diseases, what are some of the general risks or side effects that you can see?
Awesome. So again, I'll start off with the caveat: we are not in the clinic yet with this product. But across all gene therapies, when you give the dose, you can see the body react to it like a immune reaction. So people can feel like they're sick, the flu, nausea, vomiting, fevers, things like that can happen. We also know that some people can have reactions that are more severe because we're giving a lot of virus at once, where they can have things like liver inflammation, as I mentioned before, because sometimes the virus likes to go there. You can also have things where some of your blood counts change as well. Those are some of the initial in the first couple of weeks to month that people sometimes see across different therapies. Um, in There's longer risks that haven't been seen in humans. I mentioned the oncogenicities, that question of like, could there be a risk of cancers? That's not been reported in any gene therapy that I've seen to date, but it exists. We put it out there because it exists, right? It could theoretically happen. And so we want to be transparent about that piece as well. The other piece is that sometimes people will talk about, especially if you look at the Duchenne, if you try to compare to the Duchenne's field, about reaction to the protein. That is something that is less likely with Friedreich's, because in those cases, patients who make no protein and you suddenly express it, they may, and this is across any disease state, but they may actually have a reaction because it's a novel protein for their body. That's different because in patients with Friedreich's ataxia, you still make some. Right? We can measure that. There's a lot of great studies that have done that. And so then it won't be a new protein for your body to maybe not recognize. Again, these are all things that we'll have to follow in a trial with safety and learn about as we go forward.
And we did get a great follow-up question. Were there any specific safety risks that you saw in the animal studies that you're able to talk about?
Um, there were no significant safety things that were able to talk about currently. So I have a limit of how detailed I can get in terms of that, but the signaling was that we felt we're very comfortable with moving forward, and the FDA as well, having seen all that evidence, was able to clear us for IND too.
Thank you. Jen, I think a lot of questions came in during that, so I don't know if
I
you
know.
have an immediate follow-up one you want to ask.
Well, maybe that, you covered a lot of that preclinical data, right? The mouse studies and the non-human primate studies, and it's really impressive how many studies were done. And so one line of questioning is around the mouse studies. And so I think Chandra was asking, like, were the mice symptomatic when you treated them? And I think this links to some questions I saw from some of the other patients around, would we expect symptoms to get better? Would we expect things to just halt the progression? And so, did you glean anything from the mouse studies in terms of what might be expected in terms of benefit?
So that's a great question. I am going to be cautious in answering because of a couple things. One is that in the mouse studies, it's a full knockout. So oftentimes these mice don't have the gene at all. They don't have any frataxin. So it's hard to make that correlation to say how much. I think what I'm sure the people want to hear is this is what we saw in the mouse, right? A certain outcome. Can we then translate that to what we could expect in humans? I don't think we can, because there's enough of a difference between animals. And again, a mouse is a mouse, right? Not even close to how awesome we are as humans. But I'm hesitant to make that correlation that way, for a lot of reasons, but also just because they are a little different models that way. The follow-up might be, what about the monkeys or the non-human primates? But those were not knockout animals necessarily. Again, because of some differences that the preclinical team could express more better than I can about how frataxin works in a primate. Not a vet, sorry. But again, I think it's hard to make that correlation then going forward. Hence why we're starting off with this trial. And as for those who've heard about it, it's a phase 1b trial. I will say that it's very focused on safety, and trying to gather some of that initial information too.
And the non-human primate study was done very similar to what you were planning to do for the human study, in that it was both dual route of administration with the direct injection into the dentate nucleus in the non-human primate with the IV administration at the same time, correct?
One of the studies was, yes, we did a lot of NPH, or there were a lot of non-human primate studies done, but one of them did look at both, yes.
Helen, you have another question you want to?
Sure. We have some questions specific to the non-human primate studies about how the drug gets to the dorsal root ganglia. Does that come from the IV injection, or is that coming from the brain infusion?
Great question. We would not have a definitive, because I don't believe the studies were, again, as a neurologist, you'd have to do one, check the dorsal root ganglia, do the other. I don't think that level was done. From an anatomical perspective, the direct infusions, we don't expect in the brain to spread throughout the whole nervous system necessarily. Just the way other evaluations on gene therapy have been done in different models. So I can't make the definitive, but I can give you that information. You can maybe, whoever asked the question can sort of draw their own conclusions from there.
And we have some questions too, about, so you are targeting the cerebellum specifically and the brain, and do you know if that is going to relate to symptoms that would affect someone being able to walk, or are those symptoms coming from a different part of the nervous system that's not in the brain?
That's a great question. That goes back to, I think, Friedreich's ataxia anatomy and how the disease works. So this is where Friedreich's ataxia is a more complex disease, because there is components of the sensory nerves, which are the dorsal ganglia, that we know are affected, that can have sensory problems, where people can have difficulty walking. You can have some spinal cord abnormalities as well, that can occur in Friedreich's, that tends to be occurring later. So that's me as a neurologist. But then you can also have the ataxic components in the dentate nuclear, which can control coordination of gait, speech, as well as some upper limb functioning too. This is where I think when we talk about the benefits and what we might see will also vary based off where someone is in their disease process, and why it is a complex disease, to be very honest. And it is something that that's data we'll have to gather as we go forward about risk, benefit, and expected efficacy as well. So the reason we went to the dentate nucleus is we do know that is an area that affects ataxia quite a bit in Friedreich's ataxia, though I guess that's going to be sort of my summary to the question.
Yeah, and Matt, I thought you did a really nice job of explaining the role of the cerebellum and the dentate, and the kind of the whole concept of cerebellar control and movement, and why we think this is, a necessary part of the brain to be able to treat. And, maybe we didn't get to one other part, but with the IV administration, will the AAV capsid that you're using, yes, it can get to the heart. Will it get to other cells like the dorsal root ganglia that you mentioned, or, other skeletal muscle or other tissues that would be important in the context of FA?
So potentially, yes. I pull this slide back up so we can pause on it for a minute. So AAV9s do go to other tissues. We know that, and this is AAVhu68, which we're using, is an optimized version of AAV9. So there is that potential of other organs. For example, could skeletal muscle be engaged? Potentially. Could the DRGs be engaged? Potentially. Again, these are things that I'm hesitant to say definitively until we have the data, right? That's the idea of trials. But that is the idea of also the systemic dosing, is that though we're focusing on the heart, there are other pieces that we will be looking at for functionality too.
I did see a few questions related to AAV antibody testing. And so we kind of also, Matt, I think in your background section, talking about the fact that some people might already have immunity, or by, treating people with an AAV, you can only get it once. You did a nice job explaining that. But there was a specific question around, is there an antibody test for this? And is that part of what will be evaluated in screening for the trial and throughout the trial?
Absolutely. So there, as part of the trial, when maybe to start back with a clinical trial, when someone might be interested or and their physician feel they're appropriate, they come into what we call screening. And that screening process, as I mentioned a bit about choosing the participants and making sure they're the right people, will be things like making sure they don't have antibodies, because we don't want to put someone at risk. Making sure that they don't have other diseases that could make them at higher risk as well. So looking at their lab values, things like that. And sometimes doing some baseline evaluations too. That's sort of how we tend to do in the screening or baseline evaluation. You do that before you then would be told you would be eligible for the study. And then if you are, then you'd go into the trial where you'd get dosed and be followed and things like that. But that is all part of the screening process. That is something when we talk to our next talk, I'm happy to go into more details about and what that looks like. My caveat, because again, I'll be very transparent. I know some people are always questioning, well, do I have antibodies or not? I would encourage them to engage with the trial when that comes up so we can talk about what that means rather than trying to get tested otherwise. We have some natural history of what happens to antibodies over time, because I'm anticipating someone's going to ask that question too. I don't think we have amazing data of long-term, if you test someone now and yearly for years and years, what that means for seroconversion. So that would be something that I think as they talk with their physician about when they get involved in the trial, when do they want to test those type of things, but they can all talk about. But yes, a part of the trial will be looking at antibodies.
I just saw another question that maybe it's something we haven't touched on yet, but I thought it was a really good one. How long does the gene stay in the cell? How long is it there? Do we know anything about that? Or, does it continue? Does the promoter continue to work? Does it continue to be read? What do we know about the longevity of the therapies?
Oh, that's a great question too, because I think the answer is we don't know as much as we'd like. And I'm talking about across the field, not any specific product. Being DNA with a promoter, we do know that it should continue to make the protein. However, the question really comes down to is when does that DNA, that episome, ever get broken down? And that also depends a little bit on the tissue you're targeting. High turnover tissues, because that DNA should not replicate, just like your virus, I should say, that virus doesn't replicate. So I don't want people to think they're going to get a drug and then start infecting the community. And next thing we have is like a zombie apocalypse of people with too much FA protein. But so the virus does not replicate in you, don't worry. But the DNA also doesn't. So if a cell divides into two cells, let's say a skin cell, for example, you wouldn't have two copies of that DNA. Only the original cell would have it. So it depends on the target tissue, how they divide in terms of that longevity and longevity of effects. Unfortunately, the field is still young enough that we don't have 20-year data on some of these gene therapy products, even those approved by the FDA, though the research has started. in a large enough populations to really give great data that way. The durability is hoped to be longer versus a small molecule that may be out of your system and it may not be working after a few days or even a week or two. But that's great data. That's also why the trial is longer. You'll find that these the gene therapy trials we will be following patients for quite a while. Typically, it's the FDA likes to do say 5 years is how long we follow patients for that reason.
We have a couple questions about the immune suppression medication that someone might be taking as part of this trial, and that's typically involved in most gene therapy trials. Someone wanted to know, are you going to be taking that for the rest of your life, or is it just a short-term thing?
So I'll be very transparent. I don't think we've disclosed exactly what immune therapy we're doing in this study yet. I can say again, across the field, typically you do want to be on immune therapy around the dosing period when you're having that inflammation. In most trials, it is not for the rest of your life. It is something that you would be able to come off of. Most participants, and again, I'm talking about broadly approved and unapproved therapies, you would be able to come off of a immunosuppression. And that would be the goal necessarily.
And a similar question, still related to the immune system. Since there are 2 different infusions for this therapy, is there a concern that that is going to be more overwhelming to the immune system?
Great question. Likely not, for a couple of reasons. One is our immune system can take some time to ramp up after an exposure. So that's one piece of if you do them close enough together, you may not see that piece, that other part. The other part is that because one of the infusions is inside the blood-brain barrier, we don't get as much of an immune response inside the blood-brain barrier. So because of that, that response will be less. The other part is because we're able to separate out the dosing, we can actually have different doses of the same drug, one for the IDN, one for the systemic. We don't necessarily have to come at the approach and do a drug that has to cross over the blood-brain barrier. And so our relative dosing can be a little different that way relative to some of the other gene therapies. Again, I don't believe we've made that public of exact doses, but that's sort of the approach that we're looking at.
Right. So it's not the same as like if you were to receive a gene therapy now and then get one a year or 2 later, that immune response wouldn't be the same.
So this is something that by linking it in time, by doing one inside the blood-brain barrier, that response is going to look different and allow us to also be a little bit lower in the systemic dose potentially than we would have to be if we didn't do the surgical approach. And so the response should be more similar to a single type dosing. These are great questions. I do appreciate them.
Yes, it's very hard as a moderator picking which ones to bring forward. I don't want to skip over anyone.
There are a lot of questions coming forward about the, kind of the next steps and the future trial. And just want to acknowledge that, folks are asking these questions. I think that, there continues to be there's a lot of interest and people want to know what to expect. Maybe we just reiterate that we plan to have a whole webinar devoted to what the clinical trial will look like, including like inclusion and exclusion criteria. Folks are asking questions about, could they be on their current treatments if they're on approved medicines like gomabaloxolone? Can they stay on that? People are asking questions about, will this be a placebo-controlled trial? Questions about, was there going to be the need for general anesthesia during the procedure? So a lot of really, good questions, and appreciate everyone contributing those. We will have the opportunity after the webinar to go through these in more detail and share them back with the Solid team so that when we're preparing the next webinar on the trial, we know that these are the things that you're going to want to hear more about, that are important to you, so that we'll try and be able to answer them as best as possible. But I know we're not, or Matt, I don't think you're ready to answer all those questions today, right?
Yeah, not yet. And it's not that we don't want to, it's we want to make sure that we are in the right spot where we can make sure the questions are able to be answered and that we have great answers. We have had, again, discussions with FARA and other experts, and we're wanting to make sure that we're doing this as the best and safest approach in the trial. And so we are very much looking forward to being able to talk about that in the next webinar.
The maybe the one question you can answer is maybe what's the time frame going forward from here? Like when might we have that next webinar, or when, I think you said at the end that the goal is to try to start the clinical trials before the end of the year.
Yeah, our goal is that we can be in the clinic with our by the end of the year, being able to dose patients. I will caution that as we move forward, again, this is a trial that we want to be very conscious of. It is complex. We're talking about a surgical infusion, and we want to be thoughtful of that piece. So how we approach it is going to be very thoughtful and methodical in terms of moving forward. Given that, I would anticipate probably going into, and Annie, please correct me if I'm wrong, because I'm going to probably say something publicly I shouldn't. Probably going into the late summer is when we'd be looking at having this sort of follow-up webinar, such that we can then make sure everyone is aware of what's moving forward. The goal is to do this before we would start that dosing.
Spot on, Matt. Yes, we will be definitely wanting to reconnect with the FA community, with FARA, in this summer. And I do appreciate the questions. It really helps us, as we develop the materials and what we communicate in that next webinar, we'll make sure to address as many of these questions as humanly possible. And certainly if any questions do come in between now and our next engagement, we'll make sure to address that as well.
Great. Well, I think we covered most of the questions, at least at a broad level, or the categories of the questions. And I would just like to, thank everyone for joining today and participating and submitting all those great questions. And a very special thank you to the Solid team, to Annie and Matt, for, introducing us to the company and to this program, and this new gene therapy program for the FA community. And Matt, thank you so much. You covered a lot of ground in a really short period of time and did so brilliantly.
Yeah. And thank you for having us. It's been great.
Thank you so much. Thank you to FARA and of course to the community for joining today. We're super grateful. And I believe this will be also, this is recorded and will be shared on your website following this webinar. So we're grateful for all of that. So thank you so much.
Great. Take care, everyone. Thank you.
Thank you. Bye.